Welcome to our presentation, an ethnographic study into latent patterns of multidisciplinary working, leading to delays in discharge from hospital of older people living with frailty. Older people living with frailty are often unable to leave hospital when they no longer need hospital care. This has potentially negative consequences for their health and independence, and adds significant costs to health services. The risk of having a delayed discharge increases when a patient is admitted as an emergency. Clinical decision-making at the emergency department can be difficult due to the complexity of older people's physical and social conditions, making hospital admission likely. Once in hospital, older people are vulnerable to confusion and falls, malnutrition, the withdrawal of support systems at home, and the loss of muscle strength, confidence, and independence. Despite system-level attempts to address delayed discharges, they continue to be a major problem for health and care systems. This was before the COVID-19 pandemic. Hospital discharge requires complex patterns of care organisation by different professionals, which can lead to delay, especially for older people whose needs are frequently multifaceted and complex. We were interested in the sources of delay, especially those related to multidisciplinary working and care coordination. The complexity in the organisation and coordination of hospital discharges needs to be addressed in ways that go beyond agreed policies and guidelines. So we wanted to better understand how this complexity is experienced, negotiated and managed by the professionals involved in coordinating hospital discharges for older people living with frailty, and patients and their families' perspectives. We also wanted to understand why delays occur and identify obstacles that may be amenable to local solutions that could also have wider application across other health and care systems. Such insights could improve the quality of life of older people living with frailty by ensuring that they receive timely support and care in the most appropriate setting for their needs, and also increase efficiency by reducing numbers of hospital days lost to delayed discharges. This ethnographic study was conducted at 2 large NHS hospitals in 2 English cities and their respective systems of health and care delivery, including primary, community and social care services. At the centre of the study were patient pathways, the individual journeys from an unplanned hospital admission to post-hospital care, and their flow through the hospital system. The risk of delayed discharge increases for patients being admitted as emergencies. Therefore, study participants were identified by clinical teams in both hospitals as close to their unplanned or emergency admission as possible. Patients over the age of 80 years with frailty at moderate to severe level were eligible for inclusion. Following consent procedures, researchers followed patients to the wards, observed meetings, and accessed patients' records to assist in the compilation of timelines and to gather information about clinical decision-making. Observations were supplemented by informal conversations with clinical and ward staff to clarify an observed activity or discuss the procedure and elicit their perspectives and interpretations. Formal, semi-structured interviews were conducted with health and social care professionals and local system leads involved in the discharge processes, and with patients and families after discharge to elicit their experiences and understandings of the hospital admission. Data collection and analysis were carried out concurrently and iteratively using the constant comparative method. As expected, our patient journeys revealed a wide range of sources of delays because patients had to wait for things to happen or to become available. For example, investigations and specialist team reviews took time. There were delays in the provision of appropriate equipment. There were difficulties in finding care packages to meet patients' needs, and limited availability of step-down beds for patients who were medically stable for discharge inevitably led to delays. Assessments by care providers such as nursing homes were often not carried out as quickly as desired by hospital staff. However, we also found evidence of how taken for granted working practices and communication methods between different professionals and across organizational boundaries inadvertently generated delays in patients being discharged from an acute care bed. We describe what happened to patients during their admission to hospital as deconstruction, a process by which clinical and non-clinical pieces of information about a patient were gathered by a range of healthcare professionals and staff. This was followed by attempts at reconstruction, the integration of the pieces of information previously collected to enable discharge planning. These processes, reflecting routine patterns of working, shaped the ways in which health and social care professionals dealt with uncertainty and risk and had real effects on patient discharges. Older people living with frailty are at risk of experiencing crises leading to emergency hospital admissions. As with all emergency hospital admissions, a process of information gathering, history taking, clinical assessments, investigations and laboratory tests started in the emergency department to enable diagnosis and treatment. Results and reports from clinical investigations and tests tended to be highly structured, accessible, and easily retrieved electronically when required. This type of patient information was usually unproblematic. It was also highly valued and discussed at multidisciplinary meetings such as board rounds. On the other hand, professional assessments by nurses and therapy staff, their documentation and retrieval posed several challenges. Professional assessments were typically guided by a specific clinical lens that focused attention on the area of professional expertise. Their practices and methods differed, and the narratives generated as a result of the assessments were governed by professional regulation, accountability, and legal requirements. The need for information to be framed in a particular way led to information having to be sought repeatedly from patients or family members. Apart from clinical information, narrative accounts relating to the events leading up to the crisis and attendance at the ED, patient wishes, their usual functional capabilities, their level of awareness and understanding, social and family circumstances, networks of friends and family, and the availability of support were collected from patients themselves, or more often as collateral history from relatives or carers for those unable to provide accurate information themselves. We found that different types of information were collected, often repeatedly, stored and retrieved in very different ways following a patient admission. This information was mostly unstructured and likely not to being recorded at all, lost or not accessed even if it was available, as indicated in the excerpt below, pointing to how little this information was valued. The importance of accurate information about cognitive function and home circumstances was often overlooked, even when it could be crucial for differentiating acute versus chronic cognitive impairment, a vital difference affecting clinical decision-making. The note, "patient more confused than usual," frequently found in notes and handovers during our study, did not help identify if the confusion was an acute disturbance in cognition due to an underlying medical cause, or if the patient was usually cognitively impaired. This is illustrated in the excerpt you see here. The large number of pieces of information that were collected by different professionals in a mixed economy of information storage, both paper and electronically, on a variety of different systems, not universally accessible across the hospital, led to fragmentation and militated against a holistic understanding of the patient. We therefore refer to this process as deconstruction. Our observations also provided evidence that patients' deconstruction was exacerbated by other factors, including a lack of continuity of care and communication. This was the result of low staffing levels, more efficient 12-hour shift patterns for nurses who worked longer hours on fewer days of the week, patients being moved to other wards to improve the hospital bed capacity for patients waiting in the ED, as well as factual inaccuracies and distortions during handover meetings. This was summed up by family members and carers. In order to reconstruct patients and facilitate discharge from hospital, these information fragments needed to be integrated. We observed a wide range of processes in place at both study sites, traditional and newly implemented, to facilitate discharge planning through reconstructing the patient. The key component of the reconstruction and integration process was information related to patients' social, family and functional background and collateral history from other informants such as family members and carers. However, we found that this crucial component was often missing, or even if it was collected and stored, it was not necessarily accessed and was vulnerable to loss, especially if patients were moved to other wards. It was also perceived to be of low value in relation to other more readily available information, such as results from clinical investigations and assessments. Patients' reconstruction was thus often incomplete or insufficient to deal with the uncertainty and risk associated with frailty in a safe and informed manner. We found plenty of evidence of reconstruction practices by professionals, but these were often hampered by practical hurdles, as illustrated in these excerpts. And when the reconstruction process was successful and communicated to others receiving a patient into their care, the result was high quality, safe, and appropriate care. Collateral information was a key component of the discharge process, though it was often missing. We're working with our partner organizations, as well as patient and carer organizations, to find mechanisms to capture, store, and update this vital piece of the discharge jigsaw. We found that where this key component was present and integrated into decision-making processes in multidisciplinary team working, uncertainty and risk were managed constructively and sometimes avoided an escalation of care needs. Knowing the person living with frailty was not just about humanizing healthcare. It was central to safe care and the appropriate use of resources. Thank you.